Hello, everyone. Giles Boland here from the Brigham. I'm going to talk about what lessons we've learned from COVID, how that will inform leadership moving forward, and what strategies we need for radiology departments in the future. I have no disclosures. Certainly, I'll talk a little bit about COVID, but where are we going post-COVID? I think that's the important part of what we need to discuss here. What will the radiology world look like post-COVID? The way I see it, there are knowns, things that we definitely know are going to happen, possible knowns. We think some things are going to stick and stay, and then there's going to be a whole bunch of unknowns. We don't really know what the post-COVID world will look like, frankly, in our personal lives, let alone our professional lives. So what strategies should we develop accordingly? And during this ambiguity, I think it's more important than ever that we as leaders step up to the plate. This is what leaders do in ambiguous situations. They look through all the challenging events and find a way forward, focus on the particular issues, develop the teams to develop innovative solutions, and navigate our way through these challenging times. So I do think this is a particularly important time for leadership to help us get through COVID and make solutions better for ourselves and for patients in the post-COVID world. So how do we lead in this new normal? I'm not sure it is a new normal. It may be completely different. We just don't know. And that's many of these unknowns that I'm talking about. What I think we should do here is focus into sort of 4 buckets: hospital recovery, volumes, reimbursement, operations, and the future of practice. Then we'll talk about virtual care and the virtual workplace, moving on to equity, and particularly for ourselves as employees, but also for issues that have really been exposed about differences in patient care during COVID. And then finally, we'll discuss education. So what about the first bucket? Hospital recovery, financial security, and new markets. Probably most of us, whether in Europe or the United States, took a significant financial hit during COVID. In radiology, for instance, we were down to about 25% of our volume, and we depend on those volumes to pay salaries. We depend on those volumes to finance the hospital as well through all the technical reimbursement. And we took a major hit. So that means that hospitals now have to really recover from that and drive volumes accordingly to get back to financial health. And even though there was a significant emphasis on productivity and efficiency pre-COVID, it's even more so now. How do we essentially move patients through our assets more efficiently in shorter times, which is hopefully good for patients because we'll see them earlier and they're treated earlier and their care won't take so long, but also for revenue reasons. During COVID as well, we sort of rethought how we deliver care. And I think that will stick, the way we deliver care to patients, obviously from the virtual world, but we've developed many more service lines here at Mass General Brigham. You will have had service lines in many of your organizations already. An increased focus on patient experience and outcomes, and particularly because there are many new actors that have entered the scene during COVID. At the bottom left, it's an Amazon website. If you go onto the website, it says healthcare made easy, skip the waiting room and start a virtual primary or urgent care visit. And then there's also a lot of consolidation. Consolidation was always around pre-COVID, but given that many hospitals really struggle to survive, larger organizations are now acquiring those hospitals. And here is one in Michael Recht's own backyard, acquiring a very large hospital in Long Island. This was in the New York Times only last week. The bottom line is there are disruptors out there and a lot more competition. So we're going to have to adapt to those disruptors, particularly the Amazons, CVS's, Walgreens, Walmarts of this world, who are coming in to try and make healthcare more available, more ready access for patients, more customer friendly. And so we're going to have to rethink how we deliver care in the interests of patients. Let's move on to the virtual world. This is just a snapshot of what happened in COVID and where we are now in terms of virtual care for patients. At the Brigham, during the peak of COVID, about 50% of visits overall were virtual visits. Depending on the specialty, that has remained at that. Medicine's still at 50%, but dermatology is down to about 5%. Most patients are preferring to come in and see their providers. It's hard to know. This is an unknown. Where is this all going to end up? What ratio of patients will want to be seen from home versus coming into the hospital? One of the consequences of this, it's freed up a lot of space in the hospital, and we don't quite know how that's going to play out yet in terms of how we'll use that space and whether providers will come back in to use that space or patients, etc. So we're having to rethink the whole space management and whether we actually need all of that space. So as I say, it's hard to know where it'll all settle out. There's more choice for patients through this process, whether they want to be seen virtually or come into the hospital. One of the challenges, however, there are equity issues. The insurance companies pay more for a virtual visit that is a video conference than simply for a telephone visit. Patients from underserved areas, economically challenged or underrepresented minorities often cannot afford computers and smartphones with which are needed to do the virtual visits with video conferencing. So at the Brigham, we said that essentially, even though we're going to be reimbursed less with telephone visits, we will provide those services irrespective of the reimbursement, because we want to ensure that there's equity for patients despite the differential reimbursement systems. In radiology, that's had a major impact, of course, and we've all experienced this during COVID and post-COVID. And the question is, how much of our virtual workplace will stick? How much will our radiologists stay at home 1, 2, 3 days a week? Because they can just as well easily read the studies from home as they can in the hospital. The challenge, of course, is about building camaraderie, the teamwork, education, meeting with providers, etc. So again, that's a bit of an unknown where this is all going to play out. Certainly gives the opportunity for better work-life balance, and we're all for that. And so maybe the radiologists will spend a day or two at home a week, and for the rest of it will come into the hospital. But we just don't know, and you will all manage that accordingly and as you see fit. One of the things that was really beneficial to providers here at the Brigham during COVID, which was developed, and I give Ramin Khorasani credit for this, is the virtual reading room. So typically before, when a provider wanted to get an opinion, they would have to walk into the reading room or they would call up. Well, now they just go online, click on the website, drop into a reading room. And here, for instance, it's a neuroradiology reading room, and there's a video camera set up. Obviously the audio, they can see the radiologist, they can talk to the radiologist, they can go over the case, but importantly, both the radiologist and the provider see the same images and scroll up and down the images or the lesions accordingly. And so it's almost as if they're there in person. This has been a huge boon, both for radiology, because it makes us more visible, more engaged in the clinical care, and the referrers love it because they don't have to walk down. They actually see the radiologist, they see the images real time with the radiologist, and this is a definite boon coming out of the COVID world. There's been a lot of interaction virtually from the faculty. This is around conferences, training, and here is a snapshot of the last few weeks. About 100 of 130 of our faculty are using Microsoft Teams each day, whether they're somewhere else in the hospital or from home. Interestingly, there has a slow decline in this use, so we don't know where this is going to end up, the virtual teaching environment, but presumably some of it will at least stay, but this is where we don't know ultimately where it'll land. Let's move on to equity issues. As we all know, COVID and the George Floyd murder really together emphasized how much we all need to do a better job with equity, both in terms of our employees, but also patient care. And this is now an intentional process to try and correct this. And there are many initiatives, I'm sure, in your organizations to really try and get to the root of the problem. In terms of our employees, is how do we treat people fairly? How do we make our workplace look like the patients we serve? And how do we care for each other in a much more meaningful way. And part of this, frankly, is to hire people from more diverse backgrounds and underrepresented minorities in medicine into our organizations. And it gets to the pipeline. How many residents are we hiring who are people of color? How many leaders are we hiring? Now for every major leadership position in the departments, the diversity officer is included in that process to ensure that we are being as honest with ourselves in terms of how we are choosing those new leaders and that we are selecting from a diverse background. Similarly, health equity has been exposed as a major challenge through COVID, not only as this article in the bottom right here that which came out of the Brigham, where exacerbation of inequities in the use of diagnostic imaging, but frankly in the way we treat patients too. An older paper out of the Brigham showed racial inequities in access to specialized inpatient heart failure at this hospital, but it was really during COVID that people started to focus on these papers and the difference in care we give to people of color versus people who have better insurance and from different backgrounds. And so there's a major focus to correct these inequities and a lot of work to do. And this will be a major part of our leadership moving forward for many years to come, if not in perpetuity. Education, clearly that's going to change post-COVID, particularly given the virtual opportunities. Many of us have missed, of course, to be able to travel to conferences. And I, for one, certainly hope we can get back in person. Where that will end up in terms of the number of conferences that will be virtual or in person or as hybrid is hard to know. But I suspect as soon as we can, we will be getting back to meeting in person, because that's partly it is how we advance our careers. We meet people, we get ideas, we speak to people, we network, and that's very important to us. Obviously, for resident and fellow education, we've already used many virtual solutions to help improve that, and a lot of that will stay. Finally, I just want to get to the lessons learned in leadership from the experience I had at Boston Hope, which was the COVID field hospital, which I helped to set up in April last year. We went from an empty floor in a conference center to 1,000 beds in a week with staffing, all the equipment, oxygen, food, and so on. So what leadership lessons did we learn during that process, and how we cared for patients during the 3 to 4 months that the COVID hospital was operational? And how do we, with our leadership, take the way we do business normally, which is committees, sometimes sort of once a month, once every 2 months, etc. How do we really get things done? How do we, particularly in important issues, how do we get to a solution and deliverable far quicker than we might otherwise? So we wrote a paper in the Harvard Business Review led by Richard Bomer. And these were the 10 tenets that we put in this paper from leadership. And we'd like to pose that these tenets we should keep in the post-COVID world in terms of how we run our organizations and how we get things done. So I'll very quickly run through these. As leaders, we need to publicly acknowledge when we don't know the answer. That's very important. And then you delegate to the appropriate teams to find the solutions. But importantly, to those teams, focus the search. What is the problem we're trying to solve? And make sure that the teams stick to that problem that they're trying to solve, rather than get derailed and go off in different directions. Don't delay making difficult decisions. Often we don't make a decision, or we delay in making the decision. If we've got a difficult decision to make, whether it's a person, whether it's finances, or we're going on down the wrong track on a particular solution, admit it and make the difficult decision to reverse course, which is the legitimized reversal, number 6 here, if we're doing the wrong thing. Shorten the feedback cycle, particularly on the important issues. If something's important, don't meet once a month or every other month, potentially meet every week. At Boston Hope, we met actually twice a day, such that if we were doing something correct, we could keep it going and give appropriate resources to that. But if it was incorrect, we could reverse it and correct it. Set the expectations. Wherever possible, include patients and families, because at the end of the day, It's those who matter most. And then finally, as leaders, look after your people and be there. Being present is very important. They need to see us, that we're working either with them on the front lines or including them, and whether it's virtually or in person, make sure that we are there, because that's what leadership is about. And with that, I'd like to thank you. And I look forward to the meeting coming up in a couple of weeks, and really hope to see you all in person later this year. Thank you very much.